This conference will now be recorded.
Thank you, son. As a way of assuring him, connecting anything against my friend, let's file.
This conference will now be recorded.
I'm pleased to welcome you to the maiden edition of the webinar series tagged Build Back Better. As the name implies, we intend to use the webinar series to engender health system resilience in Nigeria through agenda setting, engagement, and action. At this maiden edition, we are discussing an important topic that is central to the resilience agenda, and that is the role of the public finance. The webinar discussion will unveil both international and local policy trusts, practices, and experiences that can shape our health financing landscape and set our country on trajectory of resilience and universal health coverage. We're happy to have high-profile speakers that will share experience from international, national, and state perspectives. We promise you this is not going to be another talk show, as we are prepared to translate lessons and insight from the webinar into health system resilience oriented action. Please participate actively to make the webinar as productive as possible, and we encourage you to enter your questions or contribution to the chat box on this platform. On this note, I would like to introduce Olumide Okunola of the World Bank IFC, who is our moderator for today. Olumide will introduce our esteemed speakers and continue with the proceeding of this webinar. Once again, Many thanks for joining us. Over to you, Olumide.
Thank you very much, Dr. Alawade. It's a pleasure to be here this afternoon or morning, depending on where you are. Like Dr. Alawade has said, post-COVID, the health sector would need to take a very long, hard look of how we're going to rebuild for resilience, how we're going to translate the lessons that we have learned during this period into building even a better system. Without much ado, I'd like to call on one of the global and leading experts on the concept of universal health coverage, Rob, to give us an opening presentation, and we will then have a discussion with our very distinguished panelists. Rob, over to you.
Thank you very much indeed. Greetings from Chatham House in London. I'd love to be speaking to you from Chatham House, but unfortunately we're all on lockdown, of course, at the moment. Yes, my name is Robert Yates. I'm a political health economist, and I am Executive Director of the Centre for Universal Health at Chatham House in London. And I'd like to speak to you for the next 10 minutes or so, really about the importance of universal health coverage and the public financing is the key to universal health coverage. I just got one or two slides that I'd like to share with you, and hopefully these might be coming up. Are you seeing my screen now? So I can see that looks good. So just confirming if someone can nod or tell me if you're seeing my screen. So talking about UHC and public financing.
Yes, we can.
That's lovely. Thank you very much indeed for that. So universal health coverage. Every country in the world is trying to achieve it, and met at the United Nations just last September with politicians, heads of state committing themselves to achieving that everyone, all people, receive the quality health services they need without suffering financial hardship. We're all aware that there are these three aspects to universal health coverage. First, that it is universal. Everyone should be covered, and they should receive a full package of health services, from promotion, prevention, curative services, rehabilitative and palliative care services. And in accessing services, they shouldn't suffer financial hardship. Absolutely crucial element of UHC, and has profound implications for the way that you finance your health system. And of course, universal health coverage is all about equity and fairness. You know, that it is this universe is left behind. So all sectors of society, migrant populations as well, not just your own citizens, literally everyone on the planet should receive this as their right. They should receive services allocated according to their health needs. And obviously, in the midst of a pandemic, there are some people, vulnerable populations, that have higher needs than others, and they should therefore get to the front of the queue. And this is very important when we're discussing around things like distributions of vaccines and access to hospital services. In accessing services, we should have the situation that people are financing their health system according to their ability to pay. Now, this necessarily means that richer people must pay more into the health system. If we're to have it that even poor people get access to health services, you need a system whereby healthy, wealthy members of society cross-subsidize the sick and the poor. And this is one of the sort of fundamental issues around universal health coverage. Of course, you've got to get all your other health systems reforms correct as well, but financing is pivotal. And this is very much the sort of I think the topic of our conversation today. You know, well, how do you finance universal health coverage? And here, I think, 20 or so years ago, there were sort of differing views about the relative merits of private financing and, even out-of-pocket financing. But now the world has realized that you cannot reach UHC through a market-driven financed health system like you would buy and sell other commodities and services. This will never result in UHC because, quite simply, only rich people will get the best services and poor people will get left behind. So if you are to have a system whereby healthy, wealthy people subsidize the sick and the poor, you must get the state involved in setting the rules and in compelling people to do that. And so, in a nutshell, what you're talking about is public financing. Public financing is the key to UHC. And if you look at the different financing mechanisms, that you can see that there are some very public in their nature and some that aren't. And even in the different financing mechanisms, you can see things like user fees are the worst way to finance a health system. They're very inefficient, they're very inequitable. And you now have WHO in the midst of this pandemic recommending to countries that they completely get rid of user fees to improve financial access to services. Likewise, private voluntary insurance, that people buying policies that just benefit them and their families, will not achieve universal health coverage. And if you have a market of private insurance systems, then you will tend to get better off people congregating for some services, and the poor and vulnerable will get left out. They won't be able to afford it. And of course, countries like the United States just show the folly of taking a private insurance route, but also this including what we call community-based insurance. The track record of this is very poor, and because it's voluntary, you tend to get richer people dropping out and these things not being sustainable. So at the end of the day, public financing, where the major mechanisms are out of general taxation and social health insurance, compulsory social health insurance, linking it to people's wage levels, that is the key to UHC. And someone who said that very eloquently was the former Director General of the World Health Assembly, Gro Harlem Brundtland. At that meeting last year, she was billed as a high-level champion for UHC and said very clearly, if there's one lesson the world has learned, it is that you could only reach UHC through public financing. And that's as true in Nigeria as it is here in the UK or the United States or really anywhere in the world. And this graph, I think, illustrates quite well the transition that countries are making towards UHC. Down here, these are sub-Saharan African countries. You have sort of countries with higher levels of public spending. Here shows the share of GDP, and that has the impact, not surprisingly, of crowding out private out-of-pocket spending. People don't need to be dipping into their own pockets to buy services if the government's basically doing it for them. And the UHC transition is very much about moving down this graph. And here you sit, and you're all aware of this, that in Nigeria, you have very low levels of public spending as a share of GDP, very high levels of out-of-pocket spending, leading to a lot of impoverishment and people not accessing services. And what you really will be wanting is Nigeria to make a big jump down this curve. The good news is this is exactly what we see happen, that countries don't move down these curves slowly, they make big jumps. And really that's when heads of state get involved and big decisions are made to put quite a big chunk of public financing in to reduce the burden on households. And my proposal to you today is that in the midst of a global pandemic, we're going to see a lot more of this, that actually at a time of a crisis is when countries do things like this. Again, sort of, very much relating this to the situation in Nigeria at the moment, you'll be aware of this, that as a share of GDP, public spending has been very flat for a number of years, from previous governments and into this government as well. Whereas a number of other African countries are sort of making this transition and spending more now. I flag here in particular Malawi, a much poorer country than Nigeria, but is actually spending quite a lot of its GDP through public spending. And interestingly, that means that in terms of, a key health outcome like child mortality, that Malawi, even though it's a 6th the richness of Nigeria is actually performing better now on child mortality because it's spending a higher proportion of its GDP through public spending. So, but this is easily remedied quite simply by increasing public spending, which I think is going to be the big challenge going forward. Now, as I've mentioned, the decision to suddenly put a lot of public financing into your health system is invariably led by politicians. It's a head of state issue, or certainly a state governor issue. And someone who's recognized this very clearly is Dr. Tedros, who is speaking to political leaders across the world, very much encouraging them to make a big step to UHC by dramatically increasing their public spending. And I'd just like to sort of show you in the sort of second half of my talk, just examples of where this is happening and happened all over the world. This is the Prime Minister of Thailand in 2002, immediately after the financial crisis, putting a lot of money into the Thai health system so that everyone was covered, the vast majority of the financing coming from general taxation. And Thailand is doing very well. I think they've had about 10 COVID-related deaths so far and is performing very well in this crisis. Indonesia, a country where the then governor of the capital city introduced a universal publicly financed health system, proved spectacularly successful, and it was really off this that he ran for president and said that he was going to bring this to the Indonesian people, and has been increasing public financing to pay for it. I think if the truth be known, he could go a bit further and a bit faster, but he's shown this, very much saying that the state is taking control of the health financing. And interesting that he went from a state governor to president largely on his UHC reforms. Might this happen in Nigeria one day, we wonder. Here's Tedros talking to President Kenyatta in Kenya, who announced that he was going to extend universal health coverage. And in fact, they've started this by scrapping healthcare, making it a universal entitlement to publicly financed services. And the indications are that President Kenyatta wants to scale this up going forward. In Sierra Leone, not far from Nigeria, just about 10 years ago, the president launched universal free healthcare for pregnant women and children. Obviously, Sierra Leone, a much poorer country than Nigeria, but the president doing this very dramatically happened right across the country, very successful, something I would suggest that Nigeria could do likewise. But bringing it right up to date, how could one even be thinking about suggesting things like this in the middle of a crisis? You're thinking, the public financing is under pressure. We know it's under pressure in Nigeria. So you might actually think this isn't the time to do this. My argument is this is exactly the time to be doing this, looking at the historical precedents, because across the world, heads of state are dealing with this massive crisis, requiring urgent attention by state. And what people are crying out for more than anything is access to quality health services and financial protection for them and their families and their livelihoods. And there is an expectation this should be available for everyone. No one should be left behind. It's completely unacceptable that some people die of COVID and others don't. And people want to see results quickly. Particularly where you've got numbers of cases going up and it affecting the economy, people are getting very impatient. So this is a major crisis. You don't need me to tell you that it can be changed very rapidly. And again, the historical precedent is there. China, in effect, re-socialized its health financing after the SARS epidemic. That out-of-pocket spending was getting out of control, and SARS really showed that the health system was struggling, and the government subsequently increased public financing with the view to improving access. They went from about 30% coverage around here in sort of 2000 and so to 96% by the end of the decade. And that was off the back of the SARS epidemic. South Africa, President Ramaphosa is making it very clear that he is planning to fast track what they call the NHI reforms, national health insurance reforms there, coming out of COVID-19. They have a very unequal health system in South Africa. There's a lot of pressure building from the masses to get access to the better services that the rich had. And watch this space, I'm pretty sure that President Ramaphosa is going to do with it. America, I think, fascinating. Barack Obama did a wonderful job in getting the Obamacare reforms off the ground by making it compulsory that people have health insurance. Wasn't perfect, but a big step. President Trump has come in and has basically tried to dismantle this, but it's very obvious that the Republicans haven't got a health plan and they are really, really struggling when it comes to health financing. And lo and behold, you now have the Democrats working out their financing policy going into this election. And just a few weeks ago, Hillary Clinton, in a public meeting on television, saying to Joe Biden, don't waste a good crisis. Now is the time for UHC in the United States. And I think there's a pretty good chance that this is going to be the big battle in the US presidential election. And the US might finally get to UHC off the back of this. Now, the big question, of course, for everyone today, what's going to happen in Nigeria? Will this crisis catalyze UHC reforms in Nigeria? And of course, there are big debates going on about the Basic Healthcare Provision Fund at the moment and what happens to that. And we don't know what's going to happen. But all I would suggest is now is the time to be talking to President Buhari and state governors about this, because I think you might find we have their attention with them wanting to deal with this crisis. So just to sum up, this is the biggest health crisis that we've had in over a century, and that people are looking to their politicians for quick results around access to health services and financial protection. So even though public finances are under pressure, I would say this is the perfect opportunity now to be promoting UHC to political leaders in Nigeria. Thank you very much indeed for hearing me today. Back to you, Gafar.
Thank you so much, Rob. Always a pleasure listening to you. And you have indeed set the stage for us in terms of today's topic. You brought to the fore the known knowns of UHC, which is the fact that public financing is fundamental. Indeed, no country can achieve universal health coverage without public financing. And you've given us some really interesting examples right across the world, all the way from Kenya, Indonesia, and most of them much more poorer than Nigeria. So without much ado, we go into the panel session. We have, like I said earlier, a number of distinguished panelists who are actually on the front lines of the decision making. Starting with Dr. Yemi Dipelu, who is a special advisor to the President of Nigeria, working in the Vice President's office. We have Dr. Ben Akabweze, the Director General of the Budget Office, Commissioner Magaji, the Commissioner of Finance in Gombe State, Dr. Tomi Koka, Commissioner of Health, Ogun State, and Dr. Benson Oboyo of the Gates Foundation. So if you look at that spectrum, we have people who are working at the macro fiscal space, who have a big picture of how much revenues are available. And you also have people who are making those prioritized decisions. What goes to health? What goes to education? What goes to aviation? And then at the state level, where such very hard kind of decisions are made, especially in this time. We have a Commissioner of Finance, we have a Commissioner of Health, and also a development partner in the house. So we're gonna structure the discussion along those lines, and where else to start from but with Dr. Yemi Dipelu, because a lot of times policymakers in the health sector always feel that government is not giving enough resources to health. But perhaps maybe we don't even know what is in the pool itself. So if Dr. Dipelu could give us some kind of idea what's the horizon like in terms of the macro fiscal situation for Nigeria before we then go into some of the specific actions that the government has. Dr. Dibolu.
Thank you very much, Olumide. First of all, let me start by saying thank you for inviting me to this panel. And let me say that where have you kept Rob Yates all this while? Now, with regard to Nigeria, you would of course agree with me that the picture of health financing has been a cause for concern. And of course, COVID-19 has even made the situation more pressing. As we've seen already, Nigeria spends less on health than her peers, with government spending on health at about $16 per capita, as compared to sub-Saharan Africa. The average is about $29 per capita. And the private out-of-pocket spending, which we saw in Rob's chart, is at least 72%, only is 72% of total health expenditure, compared to the others we saw in that same chart. So of course, COVID-19 has made it even more urgent to improve health coverage, health financing in Nigeria. But then we have fiscal constraints. Our tax to GDP ratio of about 6% is one of the lowest in the world. By comparison, the comparative ratio in Kenya is 15%, and in South Africa is 27% or thereabouts. Now, to compound that situation, the oil market from which we've derived a lot of revenue has more or less collapsed. So revenues falling due to the fall in prices from over $60 per barrel in February to as low as $14 per barrel and end of March, beginning of April, rising a bit, but still way, way below what was projected in our budget. And then, of course, the quantity side, we've had to make sacrifices on quantity also to reduce the pressure in the global oil supply market. So clearly for us, going forward, a solely tax-based approach to health financing may not be feasible in the immediate term due to these fiscal and revenue constraints. Now, the Basic Healthcare Provision Fund, which was set up to help ensure that there are dedicated resources for health, also interestingly faced its own problems because it's derived from 1% of the Consolidated Revenue Fund. That is basically the revenue pool available to the federal government. But it meant that when the revenues fell, the amounts going to the Basic Healthcare Provision Fund also fell, and therefore sometimes gave the impression that the commitment to financing health was even reduced. But that was not the case. Anyway, the point then is that we need to design health financing structures to supplement government financing. And I listened very carefully to Rob, and I really got a lot of insight from him. But then this is where we need, where macro needs to be talking to health experts. We have to find the balance between our limited public finances and using, as I liked what he said, if it's social health insurance, compulsory universal, then I think that's a way that I have always supported insofar as it's distinct from private voluntary financing. So bearing this in mind and taking our constraints into consideration, I thought I should just give a quick overview of how we try to respond in the economic sustainability plan. And first of all, immediate actions, of course, to boost health infrastructure, laboratories, health, hospital beds, isolation centers, testing kits, supports to states. Lagos State got 10 billion naira because it was the epicenter. But I think there is a plan to give support to some of the states as well. Of course, finding resources to incentivize health workers who are on the front line. And of course, also finding resources, either loans or grants to the pharmaceutical sector for procurement of materials and local production. But that's the immediate, that was responding to the crisis, as it were. But then we have to begin to take the opportunity, and I like the idea of using the crisis as an opportunity to begin to think of how we redefine our health insurance system in support of universal coverage, how we begin to increase the pool available for health financing, both from public sector resources, but also from social insurance. And then also begin to think of how to get more value for money in the health budget. It's not enough, but we're not even sure that what we're spending is getting the best value for money. So we have to begin to think of moving beyond passive purchasing by government allocating resources through budget lines to begin to think of more strategic type purchasing. Of course, we have to invest in supply readiness over the medium term. And one of the things we are trying to do as well is to try and create a special fund to backstop medical and pharmaceutical research so that going forward, we have a base locally to help think through some of the challenges we faced. There are a lot of other things, but I thought, given the time available, I'll just stop here for now. Thank you very much.
Thank you so much, Dr. Dipendo. In fact, you've gone beyond the what's happening at macro level to even what we need to do at the sectoral level, in terms of strategic purchasing and value for money. These are things we'll still talk a bit more on this webinar. But I'd move quickly to Dr. Ben Akabweze, who has been talking about health economics and health financing in the last 3 hours. He was on the financing forum session for the last 3 hours, and it's been a pleasure listening to him. And I'll just go straight to the point with Dr. Akabweze. So Nigeria signed into law the Finance Act of 2019, which increased our VAT rate, increased other sources of revenue. For instance, how can we get more buck, a bigger bang for our buck, especially for the health sector, if, for instance, we are able to use health damaging tax? I know you don't like to hear that word. You probably like to hear sin tax. Can things like sin tax be used for health in the current circumstances? I want to be very specific because that seems to be an opportunity within the current crisis for the health sector, Dr. Akabweze. It seems we're having challenges with Dr. Akabweze, but we will, as soon as he connects, we'll take that question back to him. So let me then move to one of the 2 state commissioners that we have on this webinar, and they are on the front lines. So I start with Mr. Mohammed Magaji, the Commissioner of Finance, Gombe State. Sir, given the decline in the revenue to states, subnationals now, and the need to invest in the health sector, which has been compounded by the ongoing pandemic, what are the strategies that you have put in place to ensure that the Ministry of Finance and Budget and Planning at the state level are able to ensure adequate financing for the health sector? Mr. Magaji.
Yes, good afternoon, everybody. Thank you for having me. As a background, I think I would like to start by giving a little background about Gombe State. It's located in the northeast of Nigeria with a population of about 3.5 million people living in an area covering about 18,700 square kilometers with a GDP of less than 1,000 and one of the lowest HDPs in the country. what we have done as a state is to ensure that we finance health and, of course, make it a priority of our government. The 2020 budget for the state 2020 budget for the state had a sectoral allocation of about 11% for the health sector, which is the largest in terms of sectoral allocation. But with the revised COVID budget, because of the COVID, we're expected to review our budgets, and then which we have just concluded. And the revised healthcare budget now has moved to about 19% of our total budget. So that gives you the kind of seriousness we are putting into the healthcare sector in Gombe State. We've also reprioritized and also, of course, ensured that spending has shifted attention to health and human capital development. That is to say that the 2020 revised budget will majorly be funding healthcare and also looking at how we can improve the lives of our people, especially with the COVID pandemic that has affected businesses and the lives of our people. Again, we have a partnership with development partners, specifically the World Bank EdChip program, which has ensured that 114 primary healthcare centers across the state are being renovated and upgraded. This is a joint project with the government. Gombe State government is contributing about $2 million to this, while the EdChip project contributes 1.5 million. So a total of 3.5 million going into 114 primary healthcare centers across the state to ensure that basic healthcare is provided to our people. With the COVID, we have also been able to upgrade and refurbish and 3 isolation centers across the state, and also established 2 ICUs, that's the intensive care units in the 2 different hospitals. We've also spent over 700 million in terms of food distribution as palliatives to our people. Aside this, there's also a tax relief which has been sanctioned by government to ensure that our businesses continue to thrive even with during the COVID period, and that they get some relief that will ensure that they continue to contribute to the state. There is a federal government 2 billion COVID intervention fund which will be applied to the renovation, upgrading and equipping of 3 general hospitals in the 3 senatorial districts of the state to complement recently recommissioned state hospital, which has also been refurbished and renovated by the state using our state funds. That alone has got over $1 billion to get it renovated. The State Assembly recently passed the bill for the establishment of the Gombe State Contributory Healthcare Management Agency, ensure universal health coverage for all citizens of the state and ensure access to quality and affordable healthcare. This, I'm sure Robert will be glad to hear that we are championing this to ensure that, of course, everybody in Gombe is able to access free and quality healthcare for civil servants and, of course, even other citizens of the state who are not workers. I also ensure, there is also a policy that will ensure that they also key into this and ensure that they get quality healthcare. Now, how do we get to do all this when we have, the COVID, and of course, when funds are also going down? It's all about priorities. The Mohamed Inuhe administration has put healthcare and health in the front burner and will continue to support the health workers through better welfare packages, conducive work environment, housing for the doctors and nurses, and of course, ensuring that whatever is needed to provide, them with good environment to work is made possible. There is also a program underway for the provision of houses for doctors and health personnel in all health facilities across the state. This we are doing with the FHF, which is we're trying to ensure that instead of building houses within the state and giving it to people, we are doing it in the health sector, providing houses in all our health institutions instead of building houses outside, but they are being built in the health facilities to ensure that even doctors who are sent to the villages are comfortable enough to remain there, because that is one major problem we have in the States. Doctors not going into the hinterlands because they don't have conducive work environment and conducive housing. What we do to also ensure that we save money is to ensure that all our contracts go through tendering and are sanctioned by the Due Process Office. We also have the Monitoring and Evaluation Unit of the Physical Responsibility Commission, which ensures that stage-by-stage checks are being conducted, while money for value audit is also conducted to ensure leakages and wastages are reduced, if not eliminated, post-project. So these are the little things I would like to share with us, what Gombe is trying to do, or what we are doing at the moment, ensuring that health care coverage, and of course, quality health is being provided for the people of Gombe. Thank you so much for listening.
Thank you so much, Commissioner Magaji. In fact, it's really nice to hear a Commissioner of Finance be very involved in what's going on in the health sector. It's not ordinary. So if that's something we've gained from COVID, it's something we do hope that kind of dialogue and that kind of really close involvement can continue post-COVID. So on the health side, we've also learned lessons, either in terms of being able to advocate for better resources, being able to spend money, being able to also use innovative approaches for service delivery. So, Dr. Coker, what lessons have we learned from this ongoing pandemic, which would allow us to build a much better and resilient health system? Over to you, Dr. Coker.
Thank you very much for inviting me to speak on this panel. For Ogun State, we realized very quickly that the pandemic brought to fore the fact that the health sector needed a complete overhaul because the access to health was very unequal, with bias towards the bias against the people in the rural area. So what we did initially is to actually audit what was provided at every local government and ward to see what sort of access each of those communities had. And the government, on realizing the challenges of funding healthcare during COVID, actually revised the budget from 11% allocated to health sector. We've also just concluded our revision, and it's gone up to 20%. Which makes it easier to actually deliver the quality care that we want to deliver. And what we're trying to do with the resources available to us is actually make sure that we allocate it appropriately to where the need is by auditing the equipment that we have and allocating the equipment to the right facility to provide the right care for the right person. And also by redesigning our care service from, we realized that it was haphazard. There was no referral pathway in our healthcare service. So what we've designed is a hub and spoke service where the primary healthcare center will deliver the right level of care to the people and then refer appropriately to the general hospital and on towards the tertiary institution. In so doing, the little funding that we have, we can actually focus it and not waste the resources on doing very costly investigations unnecessarily. And this has helped us a lot. And we also have invested in our equipment in the teaching hospitals, focusing on the high value equipment in tertiary hospitals, where the critical care for the people suffering from COVID is delivered. And this has shown us a seamless way of operating from the primary to the secondary and to the tertiary. The universal healthcare provision coverage that you're talking about is actually happening, and it's COVID that actually has made us stumble into it, because we're not charging anyone for the services, regardless of what level of intervention they require. And this is almost like a model for us, which we can then work on post-COVID, and ensuring that every citizen of Ogun State has access to quality and affordable healthcare. In addressing that, during the COVID period, we've actually also renovated 20 primary healthcare centers, all funded by the government, public funds, in each local government, each of the local governments that we have across the 3 senatorial districts. This would make it, we are intending to actually scale this up to the 236 that we have over the next 3 years. It sounds ambitious, but I think it's possible, because we're also intending to tap into the Basic Healthcare Provision Fund, which has been discussed on this platform earlier. We envisage that the drawing down of that fund as being challenging, as someone mentioned earlier, because the criteria that needs to be met by the government, the subnational government, is a bit steep we probably need to revisit that to make it easier for the subnational governments to actually access this fund and start to provide the quality care that our people and our citizens actually require. I feel post-COVID, what COVID has also taught us is collaboration with private sector. And some of the industries that we have come along with the government to provide funds for the government to invest in the health sector, and that would address the wealthy contributing to the health of the poor, and that has helped us distribute that fund into the grassroots people. So the large industries funding the healthcare for the grassroots people. One key learning that we've had is the value of the use of technology. With technology, we've been able to reach the non-reachable areas. And looking forward, it's most likely that we will be investing in telemedicine so that we can actually provide a doctor to deliver quality healthcare at the grassroots level to people who are in the rural areas, in the riverine areas where we can't reach, and to ensure that the sustainability of this, as my colleague, the Commissioner for Finance, actually mentioned, we also have provided accommodation for our healthcare workers on site. And there are other incentives that are being considered in the future to make it attractive for health workers to want to work in the rural area. When we take into consideration the provision of the right equipment, the provision of the right infrastructure, ensuring that our healthcare workers are skilled. I'm just going back to the use of technology now. We've used technology to actually train our healthcare workers to make sure that they're up to date, and an appraisal system has been developed online so that we know that the knowledge is being passed and it's being retained. That way, you have infrastructure, skilled workers, right equipment to deliver the quality healthcare that the citizens of Ogun State, I believe, deserve. And it's the sustainability that we now need to work on. The budget for this year has been appropriately adjusted, but in future years to come, are we going to be able to sustain this, given the reduction in the revenue from the industry as a result of COVID? Our GDP last year was $10.5 million. This year, we are anticipating that there will be about 40 to 50% reduction in that GDP, which then means that would have impact on how much we can actually invest in our healthcare. but we continue to look at it and change the landscape of the healthcare in Ogun State. Thank you very much.
Thank you very much, Dr. Coker. Now it's really interesting hearing from the states. First, in terms of how states are able to raise money, prioritize health within that bucket, and also how decision makers on the in the health sector are also able to be creative in the way those monies are spent. So what have we heard thus far? We had a few nuggets from Rob, who took us on a tour around the globe, you know, in terms of known loans for UHC, of which he highlighted in his presentation the role of public financing, and that indeed no country has been able to achieve universal health coverage without using public financing. And then we heard from Dr. Dipelu, who says, yes, we do agree that the role of public finance is germane, but then we have revenue challenges, you know. So how do we go from here? But COVID in itself has now even forced us to spend more within the health sector. And now we've heard from both the Commissioner of Finance at the state level and the Commissioner of Health, who is the budget holder at the state level. So I go to Dr. Benson Oboyo. Can countries or state governments spend their way to UHC? Is money as important as public financing is in this whole discussion? Can you just throw money at it? If not, what are those key principles? In fact, Dr. Dipelu mentioned some of them in terms of purchasing and all of those things. But from lessons around the world as well, what are those key things that countries need to do in order to be able to get value for that they've been given? Benson.
Yeah, thanks very much. Thanks, Olumide. Good evening, good morning, everybody. Thank you also for the chance to speak here from the perspective of the foundation. These are very early ideas, actually, not curated or agreed universally, but given the timing, we thought we can also share some perspectives on where you are coming. So fundamentally, I think what we are grappling with as I begin to address the question posed by Olumide is the fact that as now countries, including Nigeria, race towards resilience, there are a number of considerations that will be emerging there, adopting new ways of delivering care, adopting technology, working with the private sector. There may even be considerations for investing more in tertiary care institutions, given the stress and the disruptions that we saw with COVID. But we also know, as has been alluded to by Ambassador Diplo and also by Rob, the monies are not adequate there. So there has to be some sort of a balancing in terms of where you put your money. And so from the foundation, I think, building on that realization for Nigeria and looking at USC in the context of dwindling revenues and financing for health, the question then is, how do you help the government, both at the federal, but also at the state level, to be able to put the money where they should to deliver basic care in addressing USC agenda. And so we see our role as a foundation, first and foremost, in building capacity for state government and also at the federal to be able to grapple with the idea on how they make adjustments and fit within the realities of the reducing revenues. But I also build on the point that Rob made, that in the context of epidemics or pandemics, that's when governments become forthright and forthcoming with more revenues and investment in health. I also think, ambitiously though, that there'll be a lot of global financing also for health. So one of the things that we think could be done immediately in terms of positioning state and federal government to address provision of basic care in the context of dwindling resources is first and foremost to look at ways of coordinating and pooling this funding that would come from government increased investment at federal and in some states, but potentially also a lot of inflows that we've seen during the pandemic and somehow might continue through global health initiatives, Gavi, Global Fund. And so if you construct that arrangement in where you pool and address key priorities of available resources, then we can see a country like Nigeria, or whether state or federal, will be in a position to still advance a provision of priority healthcare and address their UHC agenda. I think the other point that from the foundational point of view could also be helpful is sort of generating evidence to aid some sort of priority setting. So if you have limited resources and you want to provide a basic package of care, the question is, where do you put and how much do you need to put? And in most places, I think we've been talking about inadequate funding, but without really looking at what it is that we want to shoot at in terms of what is needed to provide that basic care within a package of services, minimum package of services. So some of the early work that we're trying to help some states to do is even to cost their minimum basic package of primary health care and define how much it costs to. But if it turns out that the cost is more than the resources that are available, then how do you guide using the information that you've generated, either to move away from a broader package to a smaller package that then fits the envelope that you have? So we feel that that kind of generation of evidence that guides analysis and also decision making and prioritization within even a package of care would be a good way to go in the context of where we are with dwindling resources given the constraints in revenues that we are dealing with. I think the other point that Rob also mentioned, and we think passionately from the foundation side, and we've been doing it in a couple of states, is basically beginning to look at, are you getting value for the resources that you're investing in health? And one of the things that could be also helpful is to help the state, federal, to be able to track and begin to account for how much they're putting in, but also what are they getting down the road in terms of outputs and impact outcome as well. And with that body of information, then you can begin to tell some discussions in terms of reprioritization, but also enhancing some accountability in the use of the resources, knowing that these resources are beginning to look smaller than they were in the past. And one other lever for that, because we talk about getting government money to go into health, but a fundamental lever for doing that, in our view, is strengthening the budgeting process, a budget process that is more evidence-based, and using that to prioritize what you can do within an annual budget, and using the annual budget process to be able to lobby and influence what is allocated to health. And once you've given that, based on a credible budget formulation, then you can begin to look at how you vary the allocation within your priorities within health, so that the allocation is fit and addresses the key priorities within the health sector. So we see this body of work as critical in helping shape the agenda, moving from the ambition of UHC, but also dealing with the practical realities on where we are in terms of the revenues and the financing available for health, dealing with the question of value for money, but also enhancing prioritization based on information that we have. Now, over time, as we look into the future in terms of sustainability and resilience, the issue of universal health insurance agenda should be relooked at. Currently, the focus is more on payroll-based contributions, but as we've been told, you cannot advance UHC and social health insurance of contributions per se. Still here, then we see the role of the public financing in advancing the universal health insurance agenda. So part of the effort that you now go into this debate is perhaps a relook at the approach that we've so far advanced in Nigeria that relies largely on contributions in advancing the social health insurance agenda, given what we know. But even beyond that, if you pool public resources, including external financing, then how can you vary the way you purchase care, allocate, and defining the package of services that you want to prioritize and purchase within the resource constraints that you have, And I think this is beginning to sort of mature, even the conversations with the National Health Insurance Fund in adopting some sort of more strategic purchasing arrangements, defining how you pay providers, but also defining what you want to pay for from the providers, and then what kinds of benefit. And we are discussing these things during the pandemic and looking at how people are covered by various forms of insurance, and you always come across the limitations on the benefits that are covered there. So can we get into some conversation now with the lessons that we've learned in terms of relooking the benefits package that are even covered by the various forms of health insurance schemes that we have around? And then also in terms of resilience, there's a conversation around private sector role, and how do you then get private sector into the network, and then the issue of what you pay, how you pay, what you pay for, and so on.
We will come back to the issue of private sector involvement. Let me just quickly, there's some question that's come up, which I need to ask Rob. And I'll use an analogy, Rob, to say oxygen versus ventilator. In short, do countries continue to focus on primary care, which currently they don't have, or focus on tertiary care, ventilators, anesthesiologists, and high-level intensive care, when in fact you have not addressed the first one? Now with the pandemic, countries are more or less in a quagmire. How do we move forward with this kind of pressing questions? So that's why I capture that as oxygen, low cost, cheap, or ventilators, which right now the pandemic is saying you really can't do without. How do countries manage that?
Sure, and this is where, you know, the countries have to make difficult policy decisions. And you'll remember the UHC box, you know, that WHO showed about sort of saying that you're sort of trying to sort of work all across 3 dimensions, really. One, who is covered, you know, sort of trying to get as many people covered as possible. Then the dimension of what are they covered with, which services, primary care, hospital care, ventilators, oxygen, what have you. And then the third dimension being the financial protection. And I suppose, you know, this is very much getting into issues around politics and philosophy as much as anything else about, you know, who do you prioritize and with what services. But undoubtedly, it's the case that, you know, you get your best value for money in terms of lives saved out of a primary healthcare response. And you know, that, dare I say that even in the midst of the COVID pandemic, that you're not necessarily putting all your monies into COVID services, because if you're displacing things like vaccinating young children, or women aren't able to deliver their babies in health units, there might actually be more suffering and more deaths associated with those services than necessarily the COVID services. And one, say, looks at the Ebola epidemics that recently in West Africa, where the knock-on effect on immunization services, particularly in Congo, resulted in many more children dying of malaria than died of Ebola. So, you know, these are the difficult decisions, and they need to be sort of guided by the best public health advice about, you know, effectiveness of services, bringing in the economists to look at cost effectiveness, you know, how do you maximize the outputs. But also, this is where you have a societal view, and, you know, very much involving the population to say, you know, which population should we be prioritizing and saving next. So say when a vaccine comes along, the vaccine isn't automatically given out to maybe sort of wealthy people who are likely to survive anyway, but you prioritize the distribution of your vaccines to elderly people, to health workers, to high-risk groups. And the decision about prioritizing things like that is as much political as it is technical. So a long answer, I'm afraid, but I mean, you know, these are the difficult things we should be grappling with, but very much involving civil society and politicians in these decisions, just like we are doing in the UK. Thank you.
Thank you so much, Rob. I know, tough question, but right now, COVID is making us to now make those decisions. But these are decisions that, as technical people, we need to be able to advise the political class in a very sensible way. So I move to Dr. Olu. The question I wanted to ask Mr. Kabweze, the DG, but I'll ask you, Dr. Olu, to say, so the health sector needs money. Rob and everyone on this call has made that point that, look, without public financing, we can move forward. But then, would it be useful to say, let's begin to put some lien on some of your innovative revenue-raising efforts that yourself and the team you're working with are looking at? So we've heard about fuel subsidies being removed. We know that VAT has been increased. So there are potential for such revenue-raising efforts. Is there a potential that this can be specifically allocated to health as part of efforts for Nigeria to achieve universal health coverage? Dr. Dibelu.
Thank you very much, Olumide. I think, first of all, let me agree that the health sector needs money. I don't think anybody is in any doubt about that. So you will find that even in the 500 billion special accounts that we try to raise in response as part of the economic sustainability plan, about 200 billion of that is going to the health sector alone. But I also want to point out that I think the amount of expenditure on the health sector is often underestimated. And I give two examples. The first, of course, is that when everybody looks at the spending on health, they tend to look at the federal government spending on health. But there are 36 state governments and an FCT that also spend on health. So we need to take, I think we need to take that very much into account. The other thing is, even within the budget, say, of the federal government, you will find expenditure on health in the Ministry of Defense. You will find expenditure on health in the State House because of the State House clinic. You will find expenditure on health even in the educational sector. But the point I'm trying to make is that sometimes the amount that is given is underestimated, which is why I mentioned earlier that we also need to spend some time on getting value for money so that even what is being spent will show some results. But going to your specific question, I absolutely agree that maybe, as you said, to use the word sin taxes, I absolutely agree with that. But I think the fundamental question is that our ability to raise taxes, VAT, sin, CIT, PIT, is far below the potential of the economy. And I think it's misleading to think that just by dedicating a portion of VAT to the health sector will solve that problem. I think we have to move to issues of tax morale, issues of tax, issues of addressing tax expenditures. We have to move into issues of trying to improve tax administration. So, for instance, I read in one of the comments, someone said that Ghana dedicated 2.5% of what they used to collect to health. Excellent. But that was a 15% VAT rate. And all they did was to reduce the VAT rate to 12.5 and dedicated 2.5 to health. We are at 7.5. It's not getting anywhere. Unless, of course, you want to suggest an increase for that purpose. And then that would, of course, have to come at a political level. But the point I'm trying to make is we really have a problem of raising tax revenues. And that challenge will be with us, no matter how committed we are to sharing, to increasing the share of health in public financing. And so the point I'm trying to emphasize is, as we think of trying to raise the public finances, we have to really begin to think of some universal contributory scheme, no matter how informal the economy is. Nearly everybody has a cell phone. I'm sure there are ways and means by which they can buy health insurance, and government can also support. After all, we support people through conditional cash transfers. We support people through homegrown school feeding. There are ways, and where there's a will, there's a way. But I still think the fundamental problem has not gone away, which is that we are not raising enough tax revenue in the first place.
Thank you so much, Dr. Dipelu. We will still need and dig deep a bit more on the level of informality and the kind of effort that it will take to collect money from with such a high level of informality. Wouldn't the transaction cost be an issue? Would it not then be easier that we embed all of this under general taxes and then we allocate to health? Maybe you want to take that, Dr. Dipelu.
Okay. Let me first of all go to the point that Rob made earlier. We're going to have to find a way where those deep pockets help to pay for the ordinary person, and that is a tax-based system. I have no problem with that. I'm saying that I expect that a substantial portion of even a universal system should be borne by government. Perhaps the minimum, the last 40% who are the poor anyway in the country. Perhaps that would be a dedicated thing whereby I'm paying your share, I'm contributing your share. That's not beyond us. So I'm not in any way saying that we shouldn't try to find dedicated resources for health. I'm not saying we should go and tax the poor to death. No, I'm saying that we have to find the balance between what we can raise formally, like sin taxes, like even improving corporate revenues. Because if we increase revenues, 1% of CRF is dedicated to the health care already. So if we boost revenues, there's an automatic increase going to health there. So I'm not in any way advocating going to tax the very poor in the informal sector, but I'm saying that there are ways and means of bringing people into health insurance and government paying for the poorest, and the others we can use telephony, we can use modern methods of raising revenue. I don't think that is beyond us as a nation.
Okay, thank you very much. I go to Malam Magaji. So pre-COVID, by the way, in your earlier intervention, you listed out several things that's been done in the health sector in Gombe State. You know, I just want to ask, you know, and now with COVID, in fact, I learned that it's now commissioners of finance that are calling the commissioners of health. You know, how much money do you want? How do we deliver these things to you? Was this really the case before this crisis? Because now I presume that everyone is talking almost on a daily basis now. Did the health sector had this much attention before this crisis? Let me start with that, then I have a follow-on question to that.
Thank you. Yes, the health sector had some attention before COVID. As I mentioned earlier, our 2020 budget had health sector had the highest sectoral allocation. But then, of course, with COVID, you know that the whole scenarios have changed, and that we have to ensure that we secure the lives of people. And if you're securing lives, you're also securing their abilities to also earn a living. So that has actually brought, you know, health sector to the fore. And the reason why we raised our budget from 11 to 19% in the health sector. Aside that, of course, the state government is doing a lot in ensuring that we improve, you know, our healthcare facilities and ensure that, of course, healthcare coverage, you know, the universal health coverage is also achieved. All these are being done, well, with COVID here, yes, but there are plans that we've had, you know, over the years for improvement of our health facilities. Like I mentioned, the 114 healthcare centers that have been renovated and upgraded started before the COVID. This I remember we signed this in December, and the extension, because there were 5 local governments that were being primary health centers in 5 local governments that were being renovated by the NSHIP through the NSHIP project, but now upscaled to all the local governments in December. So that was post-COVID. But I assure you that we would continue to give priority to health and ensure that health is being funded, even as we know that our funding has now become a challenge with dwindling resources coming to the state, with dwindling internally generated revenues. But we must live before we can do anything. So health will continue to receive the required attention. Thank you.
Malamagaji, just before I leave you, if you were to give an advice to your colleague Commissioner of Health, what do we need to do better in being able to get some more money from the port? Because one of the things we're accused of in the health sector is that we probably are not able to make our case. Is that the case with you in Gombe?
Not really, because well, the planning is the planning stage. Usually you have to get it right from the planning stage. The point where our budgeting is being done, you have to ensure that the Ministry of Health is taking into consideration. They have to do their budget presentation, and of course ensure that whatever they need is captured in the budget. Most of the times, if there is no engagement between the Ministry for Health and the Ministry for Finance and Budget, of course, some of the items that they require might be left out. But for us here in Gombe, there is usually ministerial engagements that ensure that all ministries provide their budget for the years, and it is being reviewed and agreed upon and ensured that whatever policies and programs of the state are captured for the Ministry of Health in the proceeding year's budget. And aside that, there's also what we do, a stakeholder engagement, a town hall meeting that is also done with all critical stakeholders in the state. That also provides us with an opportunity to capture all the needs and requirements of each sector, of each individuals and sectors in the society. So that helps us plan actually the budget. Yes.
Sure. Thank you very much. I also have a similar set of questions for Dr. Coker. But first, to ask Dr. Coker that what we are usually taxed in the sector that sometimes we could be wasteful. When I say wasteful, that even the little money that comes to the sector is probably not spent appropriately. We spend on high-end care sometimes, the way we purchase, for instance, in terms of drugs, we probably buy branded instead of generics, So how do we demonstrate that within the sector, we are also managing the little resources we have efficiently?
Thank you very much. Unfortunately, I have to agree with you that there is some wastage in the health sector. As I went around all the primary health centers and all the facilities in the state, there was evidence of equipment that had been bought years back that were not utilized or were not maintained. And so I think in the first instance, the health sector needs to develop a maintenance culture. So all the equipment, that we have purchased during this COVID, we have to make sure that there's service agreements in place and that they are serviced regularly, that we have an inventory of where every single equipment is, and there is a timetable of when they are due for servicing, that they don't actually stop working before we service them. That would help us make our resources go a bit longer for us, and we don't have to keep buying this equipment and disposing of them when they stop functioning. So that's the first instance. And it's also looking at the level of care, primary care, what sort of investigations need to be done, what sort of health worker needs to be there to provide that care. Could we do task sharing and task shifting? That would help us make the envelope go a bit further, because as you know, doctors, the more specialized you are, the more expensive the individual is as far as salary is concerned. So when we start to look at appropriate technology at the appropriate tier and appropriate health worker to deliver that care, and if we streamline all that, then we can start utilizing our funding better and probably spread it a bit further as well.
Yes, then asking you the same question I asked previously. So you have a commissioner of finance who cares about the beating of the coin. You care about the beating of the heart. How do you manage such tensions? You know, because all the commissioner of finance wants is I need to get the economy going. Health is not the only sector. I have other priorities. How do you manage such difficult conversations? And if I may ask, you know, so do you need to have some way of also getting the governor to weigh in on some of these things, to say, oh, Mr. Governor, mothers are dying. You know, how does these conversations happen?
I'm fortunate enough that I don't have to convince my finance commissioner and budget and planning. And definitely my governor is fully behind, you know, he has prioritized providing quality and affordable healthcare for the people of Ogun State. So I'm fortunate in that instance. But the basic thing is health is a social service. It's not an income generating service. And for people, economic empowerment of a state, actually you have to ensure that the people are healthy so that they can contribute to the economy of the state. When you have unhealthy people, their productivity is reduced, and hence the finance commissioner, if he thinks about it in that sense, they cannot contribute to the revenue, and in the long run, it's to the finance detriment not to invest in health. As the common saying goes, health is wealth. So the more you invest in health, the more you would get an output of economic contribution from the people. Things as simple as maternal mortality, by attacking that, for every woman that dies, the entire family is devastated. The husband, the father in the family cannot even contribute. He has to then start to look after the children. Hello.
Yes, we lost you for a minute, but I think your point is very well made. Basically, the future is invest in your human capital development, and you will reap a bountiful harvest in the future. And I think those are some of the things that's becoming very clear now. You know, so Benson, you began a discussion on the role of data, you know, and is there potential to be able to improve our data collating efforts so that the sector can better make a case, you know, when we are seeking additional public financing for the sector?
Yes, thanks, Olumide. Yes, I think that's where our conversation is going, because we've started in a couple of states, but it's just one or two states where we've done this. But the idea would be to have some body of information that can guide decision making. I think we try to say we need data for decision making, but we doesn't quite make it available, particularly data that links to the financing and the costing of the services that are required. Right now, we have different states having costed, for example, their minimum service packages, but they are costed by different people. So you can't quite aggregate and get some sort of a coherent story that can be used either at the federal, but also even in specific states. So part of the journey, or where we think the foundation could play a role in supporting this decision process, is some support for data generation and analysis. Yeah.
Okay, thank you very much. Rob Yates, you're the UHC globally. If there was something, let's assume the next time you come to Abuja, I missed you last year, but the next time you come into Nigeria and you're invited for dinner with our president, President Buhari, and he asks, Rob, tell me one thing I need to do for Nigeria to achieve universal health coverage. What will that one thing be, Rob?
Oh, quite simple, really, and that is at least double public spending and make it a universal entitlement to everyone for free health services. And really, this is the key to success. So many of those countries I've mentioned before, Thailand and Sri Lanka and Malaysia. In the UK, after the Second World War, we were bankrupt. You know, we were dependent on US aid. You know, the country was in ruins. And, you know, it just seemed crazy, this idea that we could introduce a universal publicly financed health system. But the benefits, the health benefits, obviously, but the economic benefits in terms of stimulating growth and reducing unemployment and reducing inequalities are so strong. But just the straight down the line political benefits, that, you know, this would be a tremendous legacy for the president, you know, that to come out of the COVID crisis, having really kick-started genuine UHC reforms, and really conceptually, it's very straightforward. You need to put about 1.5% of GDP into the public health system, get rid of user fees, fund frontline services, recruit health workers, buy medicines. It's pretty obvious what you do, to be honest, but it does take political commitment, and it's a cross-government thing. But what we're doing at Chatham House, and we work very closely with groups like the Elders as well, is to have that exact conversation with heads of state. And there are numerous heads of state where we're having these discussions at the moment about, you know, you could be the UHC hero of your country. It will happen sometime in the next year, 3 years. You could be the person who does it. So my message to President Buhari, you could go down in history as the UHC hero in Nigeria, and we'd be delighted to help you do it.
Thank you so much. You know, then I go to Dr. Dipelu. In fact, in the last couple of weeks, we've had a series of engagements under the guidance of His Excellency, the Vice President, almost 5 to 6 meetings where the Vice President sat through. And I know that the Vice President would ask you, Dr. Dipelu, to say, yes, so in this meeting that you attended, what would be that one thing that you have gotten from this and we might want to consider doing? Dr. Dipelu.
Hello?
Please
Hello?
go ahead.
Yes, thank you, Olumide. I didn't know that you were such a difficult schoolmaster. I just say that really, it was very interesting exchange of views from all those who spoke, getting perspectives from the state level, getting perspectives from Rob, from Bill and Melinda Gates Foundation. I think the one thing that has struck me here is that we still have to find that balance, but that we're moving here to that balance once we understand that some form of the social universal insurance is something we have to use to complement government public financing of the health sector. But I think it's doable. What I'm hearing is that it's doable, and people are committed to finding the resources for that purpose.
Thank you so much. Malam Magaji, last word from you.
Thank you. Just like Dr. Dibolu said, the UHC is very possible, and we in Gombe State are actually trying to ensure that we implement universal health coverage. As I said, we just passed the legislation establishing the Universal Healthcare Agency. We would continue to...
Sorry, Commissioner, I just got a question. Has Gombe State released its equity fund, which is part of its state health insurance program?
Sorry, I didn't get your question, please.
You just passed your state health insurance law, and part of that health insurance law includes equity fund, which is to cover the coverage of the poor and vulnerable. So do you want to address that?
Yes, as I mentioned earlier, you know, we are not just covering the workers, we're also covering the vulnerables and also the private citizens. Government is providing funding for that, and we're also engaging with private entrepreneurs and private citizens who don't even, you know, work with any institution. There is a policy that will ensure that they also contribute certain amounts that will also ensure that they are part of the, you know, the health insurance scheme. So that is being worked out, and hopefully every other person will be under the net. Thank you.
Thank you. Dr. Coker, last word from you. Dr. Coker? We can't hear Dr. Coker.
At university mill, we'll have to take, and we can start with the formal sector. Yeah, hear me now? Can you hear me now?
You're breaking. Please go ahead.
Can you hear me?
Yes, Dr. Coker. Please proceed.
Hello?
Okay, I think we're having challenges with
yeah,
Dr.
I believe
Coker's...
Nigeria, but we have coverage. We have to take it starting with the sector. We the formal, said it is achievable for us. And I believe universal coverage both in Nigeria and given
Okay, we seem to have lost Dr. Coker. Ladies and gentlemen,
can you hear me?
Your connection is patchy, but I think the point has been well made. We have had a good session. Thank you so much to all our panelists and to you for all your questions and comments. At this point, I know we're 2-3 minutes over time, but can I move to Dr. Gafar to give his word of thanks?
Thank you very much, Olumide. On behalf of the organizing team for this webinar, I would like to thank each and every one of us for this very, very fruitful and interactive participation. You agree with me that we've had a very, very uncommon conversation, because in the past, it's very, very rare for us to bring the economic manager, finance commissioner, and health so policymakers to have this type of conversation. And a lot of important insights we have been able to get in the last 90 minutes or thereabout. A lot of insights around it's actually possible. The two states here have shown that it is possible to mobilize additional resources in the context of COVID. They've shown us how they'll be more efficient in the use of resources and how use of technology, addressing the system design and innovations have been very, very useful in terms of doing the financing of health differently. So on this note, I would like to thank our panelists, Dr. Yemi Dikelu, Honorable Commissioner for Finance in Gombe, Mohammed Mugaji, Dr. Yemi Koka, Benson Robier that joined all the way from the UK, and moderator for the very excellent work. And for participants as well, for a lot, I've been looking at the chat box, a lot of interaction, a lot of questions, a lot of useful contribution that we've been seeing. I think we need to do more of this type of conversation, and we need to take it beyond just conversation. So the organizers will look at it, look at the insight, write a very powerful blog, disseminate, and continue the conversation. So I would like to encourage you to look out, since this is a series, to look out for subsequent edition of this series, where we intend to look at a very important topic as well. So on this note, I would like to thank you very much for participating. Thank you, and God bless.
Thanks, everyone. Bye.
Bye.
Goodbye.
Bye.
Thank you.
Yeah, thank you.
Thank you, everyone.
Thank you, everyone.